And I'm a neurosurgeon at Westchester Medical Center in New York. I'm joined by Dr. Elias Rizk, a neurosurgeon at the University of Texas at Austin. We welcome you to another educational session on nerve surgery, sponsored by the AANS CNS section on disorders of the spine and peripheral nerves. In this series, we've heard from surgeons, primarily neurosurgeons, as well as plastic and orthopedic surgeons. In recognizing the multidisciplinary nature of caring for patients with nerve pathologies, we're very pleased to welcome Dr. Emily Davidson, a radiologist. Dr. Davidson is an Australian radiologist with subspecialty fellowship training in musculoskeletal imaging, currently working in Sydney, Australia at the Castlereagh and Royal Prince Alfred Hospital. Dr. Davidson, we're very pleased to have you with us today to bring a new perspective from the field of radiology. So thank you very much for joining us.
Thanks so much for the invitation to present today. So I guess we'll get started. So the talk today is going to be focusing on MR imaging of the brachial plexus as well as the peripheral limbs, and I'll mainly focus on upper limb peripheral nerves. And because it's such a large topic, there is a whole nother modality, which is ultrasound. And I'll try and show you a couple of examples and describe some places where ultrasound can be used. But for the purpose of this talk, most of the cases are going to be MR. So I don't have any relevant financial relationships to any of these cases or the techniques that are being used. So outline today is we're going to mainly focus on brachial plexus imaging, and then at the end we'll go through some upper limb nerve cases. And the topics today to discuss are going to be trauma, tumor, neuritis, as well as some iatrogenic injury cases. So why do we want to do MR angiography? So MR angiography is the same as MRI. It's just that we use the term neurography to encompass the sequences and the techniques that we do to maximize our nerve imaging. So we're essentially using the same techniques, but it's just a different name. And the reason why we might want to do MR angiography is so that we can localize a particular nerve injury. And this could be a focal injury or multifocal. We can evaluate for a pre or postganglionic injury in the setting of brachial plexus. And we can evaluate a brachial plexopathy. So if there's a lesion and we want to use it as an adjunct to electrodiagnostic testing, but we can also use MR angiography to influence surgical planning, whether it's a pre-surgical assessment or to monitor for post-surgical outcomes. And the advantage of doing MR angiography as opposed to, say, ultrasound is that we can get a really good global assessment of the nerves as well as the muscles, and particularly deeper muscles around the shoulder girdle. And this can be helpful for looking for patterns of denervation and the extent of nerve pathology. Now, ultrasound of the brachial plexus is difficult because we have the clavicle, the first rib, and the axilla can be quite challenging to access under ultrasound. But where I typically use ultrasound is in a dynamic assessment. So in cases of, say, thoracic outlet syndrome, where we're looking for any kinking, distortion, tethering on the nerves, for example, particularly in that supraclavicular region. And the advantage here is that we also get simultaneous vessel assessment. And I use ultrasound predominantly for imaging guided procedures, whether it be Botox injections into the scalenes, or if we're injecting steroids or local anesthetic around irritated nerves. And in certain nerves that are more subcutaneous, such as in the suprascapular nerve or the spinal accessory nerve, we might be able to assess those more easily under ultrasound because they're quite superficial, and we can look for discontinuity or neuromas or constrictions in the case of Parsons-Turner syndrome. But some patients are not that sonographic, so we sort of use it as an adjunct in brachial plexus imaging. Now, I wanted to go through just the basics of MR neurography or MRI of the brachial plexus and some of the technical components. So we always get asked, well, what magnet do we want to use? And the strength of the magnet really matters when we're doing MR neurography, because we want to generate as much signal as we can and signal is generated by a higher Tesla field strength. And by having a high strength and high amount of signal, we can get really good spatial resolution. And spatial resolution is the key for doing nerve imaging. We also like to do these with a wide bore magnet. And part of the reason for this is that we can position the center of the brachial plexus in the center of the magnetic field. And this is where we're going to get the most homogeneous signal. If we start to move the patient or the area that we're imaging onto the periphery and they're touching the side of the bore, then you start to get issues such as in this case where you get sort of black areas on your pictures. So having a nice wide bore means that you get really good signal. And the other advantage of having a wide bore is that you can combine different coils if you need to. And the coils are these things that we put over the patient, which helps us to pick up the images. And we can reposition the patient if we need to, such as in this case where we can put the patient in ABA in cases of, say, thoracic outlet syndrome assessment. So the general principles for MR neurography or MRI of the nerves is to maximize the spatial resolution. And spatial resolution is ability for us on a picture to be able to distinguish two separate structures on one slice. And in order to be able to do that, we have to reduce our field of view and maximize our signal to noise ratio. And we do that by giving lots of signal from our 3 Tesla magnet and using small flexible coils. And we do only a single side of the brachial plexus. I don't do bilateral brachial plexus assessments. We really want to get as much imaging and information as we can from one side. Now, there are different coils that we as a radiologist can choose from. And the coil selection really matters here because we want to have the coils, which is where it's going to pick up the signal in order for us to generate the pictures as close to the body as possible to the area that we're imaging. And so we really need a flexible coil that can conform to the curvature of the neck and the shoulder. And that can be quite awkward to position these coils. And most of them are quite rigid. So in this example here, we've got this neurovascular array, which is typically used for head and C-spine imaging. And this was traditionally how brachial plexus has been imaged in the past, but particularly by neuroradiologists that have often performed or interpreted brachial plexus imaging. And you can see here you've got large gaps over the shoulder here. This part over here of the chest plate is not a very high channel coil. So this is not really giving us much information over the neck. It's really centered on the head. This is a current setup that I use at Castlereagh as well as at my public institution at RPA. We use these sort of semi-flexible coils. They're only flexible in sort of one direction, and we position them as close as we can to the neck, and we sort of have to strap the patients in. But these are the coils that are typically used by, say, a musculoskeletal radiologist when you're assessing, say, the elbow or the hand. So we're sort of using different coils here to image. But be aware that there's these new coils that are becoming available, and these are going to be more widespread in the next few years. And these are these wearable coils, and you can sort of position them over the patient, and they're quite flexible. So you get really nice skin contact, and that means that we're getting really good signal from our pictures. And also patients find them much easier to wear. They're less claustrophobic. So that's where we're looking at in the future is coil technology. Now, the critical imaging planes here are to obtain orthogonal imaging of the nerves, and this gives us the ability to assess nerve pathology. We want long axis imaging. So in this case, this is a 3D sequence, and it means that we can reconstruct along the length of the nerve, and we can look for areas of longitudinal discontinuity. In this case, this was some constrictions here in the suprascapular nerve, and this is a case of Parsonage-Turner, but equally we could look at it to see if there's any trauma, and we're looking for focal gaps in the nerve or thickening in the nerve. So this really gives us a longitudinal assessment. Then we want a cross-sectional assessment of the nerve. And this gives us a detailed anatomy of the fascicular architecture, this honeycomb dot-like appearance of the nerve fascicles. And you can see here that these are quite high resolution sequences. We're able to actually pick out the individual fascicles in these chords here of the brachial plexus, which you just wouldn't be able to achieve if you did a large field of view bilateral exam. The critical sequences for imaging of nerves, so MR neurography, is to have T2 weighted sequences because T2 shows up edema, and what we're looking for is nerves that have edema and more water in them, which is what is manifested as nerve pathology. And then what we want to do is fat suppress our sequences so that we improve our contrast resolution, so our ability to distinguish between black and white. This increases our ability to distinguish normal and abnormal nerves. So here's just a nice comparison further illustrating that. We have here on the left a T1 sequence, in the middle a PD sequence, and here on the right a T2 fat suppressed sequence. So on the T1, and I'll increase these up, the nerves are positioned here in the interscalene triangle, but they have almost the same signal as the adjacent muscle, and it's very difficult to look and see any of the small nerve branches. It's almost impossible. Whereas when we go to the PD, which is slightly more weighted in a T2 fashion, we start to see the nerves, but not quite as good as the one on the right here, where the nerves are really nice and bright in comparison to the background gray or black areas of muscle and fat which have been suppressed. So this is the reason why we do these sequences with T2 weighted fat suppressed imaging. Now, the typical planes and the plotting that I tell my technologists and radiographers is that we're obtaining imaging again to get longitudinal and cross-section. So the longitudinal imaging is actually slightly obliqued in a coronal plane because you've got the nerves and the vessels heading from the neck all the way to the axilla. And then from the neck to the axilla, they have an oblique course in the sagittal plane or the cross-section plane. So we are able to plot for the different angle as it moves down into the arm. And that's how we acquire our two main sequences, our longitudinal and cross-sectional. Now, contrast, I get asked a lot to do examinations with contrast. And contrast is not really useful to look for nerve pathology. And this is because contrast needs to be done with a T1 weighted sequence. And we just spoke about how T1 is not very good at looking at nerves. And nerve pathology shows up as edema, and that's better on T2 weighted sequences. So contrast is almost, we never really use it apart from in certain circumstances. And this would be an example where we'd use it, is where we're getting so much vessels obscuring our assessment of the nerve that we really can't make out which is nerve and which is a small vessel that's traveling with the nerve. And we have a technique where we can give gadolinium to then suppress out all the vessels, particularly those small veins and lymphatics that can obscure. And then we get really nice cleaned up pictures where we can see the nerve itself. So contrast I use for vascular suppression in cases where there's contamination, and then in cases of tumor where we're looking for tumor enhancement. But for general nerve pathology, trauma, neuromas, Parsonage-Turner, we don't really need contrast at all to make the diagnosis. And this is just an example of how it works. For those that are interested, is that the gadolinium shortens the signal in blood, and when we perform our sequences to null or suppress out the fat, the blood goes along with that, and so it gets suppressed in the images. So I thought it'd be useful to go through the anatomy of the brachial plexus and what it looks like on MR. Now, it doesn't look like this. which is what we often get trained in medical school and even as residents. But it's a sort of general overview diagrammatic representation. But we're going to go through what it looks like on MR. So we're going to start with more proximally. You can see here, this is, if you follow these, this is depicting where we are. This is up at the neck, this is the shoulder, and the green line is depicting this particular slice. And we're now at the interscaling triangle level, and we can see the stacked appearance of the nerve roots. And we can know that which one is which based upon the first rib. So if we find the first rib, then we can count that the nerve root below it is T1, the nerve root above it is C8, and then we can count backwards and we get our 5 nerve roots. We can also start to see smaller nerve branches. So these are the C5 and C6 nerve rootlets of the long thoracic nerve, and they're going to form in the scalenus medius. Moving further downwards, we have this 3 stacked configuration of the nerve trunks, so upper, middle, and lower. And we start to get smaller branches coming off, suprascapular nerve from the upper trunk, and we're starting to see the nerve rootlets of the long thoracic that are going to converge in the scalenus medius. Now we're at the level of the sort of divisions, early chords. Here we have the upper trunk has divided into its anterior and posterior divisions. On this particular image, the divisions have probably already formed the chords, but you can almost get this sense that there is a sort of elongation to them, so that it's anterior and posterior components of each of those. And again, those smaller nerve branches. Here is a more classic appearance of the chords, this triangular configuration above the axillary artery. The easiest thing is to identify the one at the top, and that's the posterior chord. And then we can work out which is the medial, which is closer towards the chest, and the lateral chord is closer towards the arm. Heading further laterally, you can see where we are. It's in the axilla. We're getting to the terminal nerve branches. I like to identify those that come off the posterior chord first. The axillary artery is at the top, and the larger one down below is the radial artery. And then I work my way around to identify the rest of the nerves. The big one just below it is going to be the ulnar nerve, as well as the medial chord branch of the median nerve. And then arising from the lateral chord, we have the musculocutaneous nerve, and then the lateral chord contribution of the median nerve. And moving further down, we can see that those 2 medial and lateral communication of the median nerve is going to join along the undersurface of the axillary artery there. And we can also see in this case some nice small nerve branches here. This is not always the case. Small vessels or respiratory motion can obscure some of these, but in this case, it's a nice example where we can see everything. Now, this is a freely accessed resource. It's on the HSS website. You can just type in HSS Nerve Atlas and it will take you there. This is the link. And it's a scrollable resource where you can put on the labels or take away the labels, and it gives you, particularly if you're using MR neurography in your practice and you want to know and follow along with what the radiologist is talking about, this can be a helpful tool, as well as for those that are learning their anatomy. So let's go through some cases. We spoke about the advantage of having simultaneous nerve and muscle imaging on MRI. And this is a nice example where we have a peripheral neuropathy, denervation changes of the infraspinatus and the supraspinatus muscles. And then that prompts us to go and look at the nerve. And on this longitudinal assessment, we can see that there are some focal gaps in the nerve architecture. And this is a pretty classic presentation of Parsonage-Turner syndrome, or brachial neuritis, or neuralgic amyotropy, depending upon which term you want to use. These often affects young people, sort of minor trauma or infection. Here's another example of that classic dense denervation. This was a young patient. He was 16 years old, 46 years old, and developed acute onset paralysis. And we're looking at these constrictions. Now, the thing with this is that we look at this denervation pattern first, which then helps us to go and look for those particular nerve. So the astute one here will notice that actually serratus anterior is also affected. So we had to go and specifically hunt the long thoracic nerve here. And we can see these constrictions. Now the constrictions are actually focal gaps in the nerve, and it's caused by these torting of the outside layer of the nerve, and this corresponds to what we're seeing on the imaging. We can use ultrasound in these cases. It's really nice in the upper limb, but in certain cases of the brachial plexus, particularly suprascapular nerve, we can use ultrasound. In this case, this gentleman was quite skinny, and sonographically, he was able to be scanned quite well on an ultrasound, and we could see his axillary nerve in this case, and he had some constrictions there too. This is a case of a patient who'd had a previous schwannoma that was resected, and it's just a nice example of highlighting the difference between performing this sort of older style bilateral exam, where we're comparing right and left, compared to a unilateral exam. On the bilateral exam, we can see that the lesion is mid-level of the plexus, but on the unilateral exam, we can actually localize it to the upper trunk posterior division, a recurrent schwannoma. The advantage of doing longitudinal 3D sequence is that there are some labs and techniques to render these in a 3D sort of movie-like configuration. And this can be quite useful for surgeons discussing tumors, for example, or lesions with patients. And it looks pretty cool. This is a tumor case, a very large mass extending from the supraclavicular to the infraclavicular. And with tumor cases, we always get asked, is it arising from the plexus, or what is its relationship from the plexus? Is it causing mass effect on it, or is it actually arising from one of the nerves? When we zoom up here and we look at the T2 fat suppressed sequence, here's our nerves, our cords or sort of division level. They're being squished inferiorly by this mass. It sort of looks separate to it. I like to do this PD sequence. This helps to highlight the fat planes around the tumor. We can still see the nerves, but on the fat suppressed sequence, it's a little bit harder to appreciate. So a PD sequence is really helpful in tumor cases. And here is an example of T1. It's really not helpful at looking at the nerve, and we can't really see the fat plane very well, but we do T1 in tumor imaging because it helps us to characterize the lesions. And in this case, this was thought to be a solitary fibrous tumor and not actually arising from the nerves. So moving on to some trauma cases. I always get asked, when can I image this trauma case? And the question I give to people is, well, is it a high velocity or low velocity mechanism? Because that's really going to help to determine when you can image. And if it's a high velocity and you've got a lot of edema on your area that you're imaging, it's going to essentially obscure your assessment of the brachial plexus on MRI. Because remember, nerve pathology is edematous, and then if you've got lots of swelling and blood and fractures and injury to vessels, etc., then you really can't see much. So a high velocity mechanism, I like to wait at least a couple of weeks before all of that edema settles. And also the nerve surgeons that I work with, they like to see what the true nerve deficit is, because sometimes you can have a nerve pathology and it resolves after a couple of weeks. So it really helps to indicate the clinical manifestation. A low velocity, you can essentially image them straight away. I also advocate for not doing emergency after hours brachial plexus imaging. I really want my best team on site, my most senior radiographer or technician that knows how to scan these. And I want the patients to be comfortable, relaxed, not move during the scan. If you're doing these after hours, often patients are very stressed, they're unwell, they've got other problems, they've got lines and tubes, and then your picture's essentially non-diagnostic. So you want everything to be nice and relaxed and in hours and not rushed. I like to use the nerve classification system to describe the nerve pathology and it's just a increase in level of nerve disruption. And we can see some of these features on MRI, these internal loss of fascicular detail, as well as focal areas of complete transection. So this would be a case of a lower grade injury. This was a professional rugby player, and we can see on the large field of view, we've got some patchy areas of denervation and a long segment of signal hyperintensity and some fascicular enlargement of this axillary nerve, but without any discontinuity. So we suspected he had a neuropraxic injury. Compared to this patient who was a motorbike accident, this was scanned 10 weeks after his injury. And we can already see that there is denervation patterns happening in the deltoid. So when we go and look at the axillary nerve, there's abnormality over about a 3 centimeter segment, but there's this focal expansion to the nerve and potentially a break in the nerve architecture through here. So the question is has there been a transection or a high-grade exenatomesis, and now you've got a neuroma that's formed at that neuroma in continuity at that axillary nerve. Whereas the radial nerve was just slightly thickened and bright, as was the C7 nerve root. So we thought that they had a neuropraxic. And when we look at the cross-section on that axillary nerve, we just don't have that dotty appearance that we see, say, with this radial nerve. We've lost that. So again, that supports that concept of potentially a neuroma. Again, another high-grade velocity injury 4 weeks after. This was repeated. The original study was non-diagnostic. We can see he's got large segments of discontinuity of the nerve. The C5 and the C6, we've got postganglionic root avulsions, and the nerve stump edge is retracted to the interscalene triangle. The C7 is lacerated at the upper trunk level, and the C8 and the T1 have pre-ganglionic root avulsion. We just don't see any nerve architecture in the neural foramen. We have pseudomeningocele, and when we look, we can see the stump edges retracted even further. And again, on a cross-section, we don't have any neural elements in the interscalene triangle, and they're all retracted back to the sort of costoclavicular space. The sequence that we've been doing more and more for proximal nerve root injuries is this 3D. It's a heavily T2 weighted gradient sequence. Gradient is just another type of sequence that we have in our arsenal of imaging. And what it does is it means that we can reconstruct it in 3 planes. It's very sensitive to motion, so you'll notice that the CSF is nulled out, and so are all the vessels, and that's because the flow of CSF and the blood are moving, and it gets nulled by the technique of the sequence, and we get really nice nerve anatomy. And we can see here that there is discontinuity, and there's sort of haphazard appearance of this internal nerve architecture, suspected to be a high-grade exenatomesis. And this sequence is really good at looking at the nerve root ganglion as well as these nerve rootlets in the spinal canal. This was a case of a patient who'd had previous axillary nerve palsy and had had nerve grafting and was starting to get new deltoid symptoms, sensory changes, paresthesia. And so we knew that there was going to be something wrong with the axillary nerve. And when we go and look at it, we suspect that there's probably a neuroma that's formed. So the question is this a tumor? Well, I think it's the clinical context, the fact that they've had nerve grafting through this location, previous nerve trauma, that fits more with a neuroma. We can also image around metal. In this case, there was concern that the nerve had been incorporated in this recent reverse total shoulder arthroplasty. And when we do special techniques to suppress out all this magnetic pileup artifact that forms, we can see that the nerve is actually clear, but instead there's probably a traction neuropraxic injury of the mid portion of the plexus division to cord level. So it's probably occurred during the surgery. And similarly, longitudinally, we can see in this case of a patient who'd had a previous shoulder dislocation and capsule and labral repair arthroscopically. Unfortunately, their sutures that they've passed through the anterior capsule have gone beyond the capsule and have skewered the radial nerve as well as the median nerve here. And you can see that discontinuity of the nerve architecture in this mid portion. Moving on to thoracic outlet syndrome. I'm increasingly imaging more and more of these, and I think it's partly because patients are becoming more educated as this as a pathology, and maybe it's because of Google AI or people are just sort of researching more, and it's and as well as clinicians being more aware of it. But there are so many different etiologies that could be contributory to thoracic outlet syndrome. But the key element is that it's because of some sort of compression as they traverse the thoracic outlet. And there are sort of different entities depending upon which structures are compressed. It's helpful to understand the anatomy of the thoracic outlet, and we like to divide it into sort of three zones. We've got a supraclavicular or interscalene triangle formed by the scalenus anterior and medius. We've got the costoclavicular space at the level of the clavicle, the first rib, and the subpectoral space formed by the pec minor and the chest wall. For the imaging side, we do the same setup as we do with our standard MR angiography, but we add on some additional sequences depending upon what the quick clinical question is. I always add on these sagittal oblique, or sorry, they're sagittal straight PD sequences, and that gives me assessment of the costoclavicular interval, and we get the patient to reposition their arm in ABA, and we look for narrowing. But we can also do other things like do a CT-like sequence to look for any bony pathology. And then we can perform MR angiogram, and this means that we can do simultaneous nerve, bone, and vascular assessment without the need to go and do a CT. So this would be a case that we would attribute to as a dynamic impingement. We see signal hyperintensity and enlargement of the upper trunk and sort of the upper trunk divisions. And then when we go and look at those dynamic views, we can see that it's significantly narrowed costoclavicular interval. So every time this person puts their arm above their head, they're probably crunching down on that upper trunk. And this is a sort of classic pattern that we see. And this might be a patient that we would recommend for intramuscular Botox injection. We target the scalenes, and in this case, the scalenus anterior and medius, and here's the needle passing through into the muscle, as well as here, and the nerves are in the middle here. And we target the muscle bellies that are very close to the nerves. And what that does is it just helps to, in conjunction with a really heavy rehabilitation program, help the patient to retrain the muscles around the scapula and the thoracic outlet to alleviate that postural dynamic compression. In this case, as an alternative, this is not a candidate for Botox. This person has a synostosis with a cervical rib, and this is our CT-derived MRI sequence, and we can see this communication here. It's producing this bulbous appearance, and the nerves are actually draped over it, and they're very thick and very bright. And every time she lifted her arm above her head, this whole thing got caught beneath the clavicle, and so she's significantly compressing. So she needs to see a surgeon for the removal of these bony abnormality. We also see cases of previous thoracic outlet surgery and with recurrent nerve symptoms. In this case, this patient had a previous venous TOS surgery, partial rib resection. But when we do our neurography sequences, and then we also ran this PD sequence so that we could look at any scar tissue or fat planes, you can see that this first rib is actually abutting the C7 and C8 nerve roots here, and it's probably causing nerve irritation and tethering. Whereas in this case, this patient had previous thoracic outlet syndrome for nerve TOS, and it had a scalenectomy and as well as a neurolysis, but had recurrent symptoms. So we were looking to see whether there was the rib had been adequately resected. You can see it's all the way back to the transverse process. It's not abutting the nerves, but we can see on this PD sequence that there's actually some scar tethering that lower trunk and irritating that anterior division. So moving now onto some peripheral nerve cases of the upper limb. I like to get my clinicians to really narrow down where we're going to image. It's really hard to do a nerve assessment thoroughly on MRI if we don't know exactly where it is. So this could be with electrodiagnostic testing or clinical exam to sort of identify where we think the nerve pathology is going to be. And that means that we can put a high channel coil over that particular area. So if we think the nerve pathology is at the elbow, we want to really scan the elbow rather than scanning the whole limb. And then following that, I like to perform all of these cases with a targeted ultrasound. And that might be on the same day or in the next couple of days. And that way, depending upon what we see on ultrasound, we might put them back on the magnet if there is something that's not quite clear. And I think that they're really complementary modalities and particularly the upper limb and even the lower limb nerve assessment. The sequences are essentially the same. It's just that it's a lot more straightforward. We're not dealing with those angles that we're dealing with in the neck and the shoulder. And so we can just do straight, plain axial, so cross section, and then longitudinal, either coronal or sagittal. And the main sequences here are going to be really thin slice, fat suppressed T2 weighted sequences, as well as a PD sequence. And this is a fast spin echo. And the PD gives us assessment of the fat planes and any scar tissue. And the fat suppressed T2 sequence looks for the nerve edema and pathology. And then we run that gradient echo sequence that I was telling you about to get a 3D longitudinal assessment for nerve continuity. In this case, this is a patient who fell off a bicycle a couple of weeks ago. You can see there's quite a lot of scar that's formed around the ulnar nerve, particularly superior to the cubital tunnel. And then when we follow the nerve, it's diffusely bright and enlarged. This is probably sustained some sort of neuropraxic injury. This unfortunate patient had an epicondyle fracture, underwent K-wire, and we think that potentially the K-wires have caused quite a lot of irritation and scarring to the nerve. And the patient even underwent a further ulnar nerve transposition, but we can see that the nerve architecture looks abnormal. And if we zoom up, hopefully we can see here the posterior aspect of the nerve has got these fascicles, but the more anterior portion of the nerve is sort of, it doesn't have that nice fascicular detail. And we could see that that was spanning over a length of about 3 centimeters. So it's probably got a neuroma and continuity through this whole section and quite a lot of scar formation. Sequences that are quite impressive, mainly used in research and sort of academic centers at the moment, and potentially will be used more widespread as these diffusion tractographies. And this is where we sort of obtain information along the length of the nerve, and we can look for the nerve fibers. And potentially with the use of AI as well, this will help to make these more commercially available. But it's a really nice demonstration of this nerve, radial nerve, that was incorporated in this healing callus, and so was tethered in the bone. And you can sort of see that part here. We also get neuropathy or neuritis that affects the peripheral nerves of the upper arm, and this is a case of presumed Parsonage-Turner syndrome. We have some denervation changes in the anterior interosseous nerve distribution, so pronator quadratus. the radial side of the flexor digitorum profundus and flexor pollicis longus. And when we go and look at the median nerve above the elbow, as well as just below, we can see that the posterior medial bundle of the median nerve has got high signal and is thicker than the other fascicles. And this is a pretty classic case of a neuritis affecting the AIN of Parsonage-Turner. In this case, the patient had had a previous biceps tendon repair, and the anchor has gone through the radial tuberosity, and one of the nerves that is at danger of being injured in this particular surgery is the lateral antebrachial cutaneous nerve. And here on that longitudinal assessment, we can see that there's a break in the nerve longitudinal architecture, and so it's been lacerated. And the two stumps are retracted and are hyperintense. And lastly, this is a case of multiple schwannomas. We can tell it's a schwannoma because it's got this internal murky appearance, and also on the longitudinal assessment, which I don't have a picture of, but it's got a slightly tapered edge compared to, say, a neuroma, which is sort of contiguous with the nerve. And in this case, we were following them up because of the multiple lesions. Once they get to a certain size, there is question of whether they have malignant transformation. The PD sequence is really good at looking for the adjacent fat plane, and then the T2 fat suppressed sequence really highlights these lesions quite nicely. So we went through brachial plexus imaging, some anatomy and general principles of imaging of the nerves, as well as a few cases of upper limb nerve. And we mainly spoke about trauma, as well as some thoracic iliac compression cases, as well as a number of iatrogenic injuries and what that means, and tumor and neuritis cases. I'd like to thank my mentor, Associate Professor Daryl Sneeg, who I've done quite a lot of research with and trained under a couple of years ago when I did fellowship, as well as Dr. Exun Tan, he's the associate scientist at the MRI lab, who we've also worked quite closely with. And thanks so much for your time and for listening.
Thank you so much for this wonderful talk. It was definitely very thorough and complete overview of imaging of the nerves. And I'm sure Dr. Pisapia, do you have any questions for Dr. Davidson?
No, I agree. Dr. Davidson, that was an excellent overview and really appreciated the cases and all the background. Thank you so much.
No problem.